Pal is not your friend. Beta-lactam allergy practice update. My name is Sarah Lessard, and I'm an antimicrobial stewardship pharmacist presenting this important topic for the 2023 Pharmacy Society of Wisconsin annual meeting. For the purposes of this presentation and topic, I have no relevant financial relationships to disclose. After completion of this program, pharmacist and pharmacy technician learners will be able to identify risks associated with use of non-preferred antimicrobials in patients with penicillin allergy label, describe the recommended practice for use of cephalosporins in patients with penicillin allergy label, and list the benefits to delabeling a patient's penicillin allergy label. For this presentation, we'll talk about the issue at hand and describe why PAL is not your friend. We will also review the history of penicillin allergies and where cross-reactivity concerns between the penicillins and cephalosporins came from. And finally, we're going to discuss the strategies to address penicillin allergy labels, including optimizing the use of beta-lactam antibiotics in patients with penicillin allergy labels, and delabeling penicillin allergy labels. Penicillin allergy label is overreported and leads to significant negative impact on patients. Over 10% of the population reports a penicillin allergy, but less than 1% of the population is truly allergic. We have a long-standing history of avoiding use of beta-lactam antimicrobials in patients with a penicillin allergy label. We've all seen and experienced these clinical situations of uncertainty or fear with patients who have penicillin allergy labels and need an antibiotic for treatment of an acute infection. Historically, use of cephalosporins would have not been advised in patients with penicillin allergy labels, especially with those reported anaphylaxis to penicillin. However, beta-lactam antimicrobials are typically preferred in many infectious disease states based on clinical outcome data. Let's look at some real-world examples. With history of anaphylaxis with penicillins, I would be reluctant to use cephalosporins. She has such a severe reaction to penicillin that I wanted to avoid cephalosporins, so I did actually place her on Zithromax. Because she's allergic to penicillin and had an anaphylactic reaction with this, I did not feel it would be appropriate to risk using cephalosporin and did use clindamycin. I'm not sure what the protocols say, but her listed reaction to penicillin is anaphylaxis. I am quite reluctant without preoperative allergy testing to give it to somebody who had had an anaphylactic reaction to penicillin. In these situations, you can palpate the provider's hesitancy to use beta-lactam antimicrobials because of the patient's penicillin allergy labels, and this resulted in use of non-preferred antibiotics for patients' infection or surgical prophylaxis. Data from the 1960s and 1970s indicated a possible link of cross-reactivity between penicillins and cephalosporins, and it was postulated that the beta-lactam ring structure was the source of this cross-reactivity. However, contamination of cephalosporins with penicillin were noted in products prior to the 1980s. Despite this, safety alerts in package inserts and electronic health records continue to indicate a potential cross-reaction between penicillins and cephalosporins, keeping the cycle of the concern of cross-reactivity between penicillins and cephalosporins alive. As you may recall, penicillins and cephalosporin share a similar four-membered lactam ring seen in the green highlight on the chemical structure. However, the antibiotics have different side chains depicted by the blue highlighted box. Penicillin has a 4-membered lactam ring fused to a 5-membered thiazolidine ring, where cephalosporins have a 4-membered lactam ring but fused to a 6-member dihydrothiazine ring. Historical incident rates between the potential cross-reaction between penicillins and cephalosporins has been reported to be 10 to 20%. However, data has since suggested these reactions were due to product contamination or were the result of an underlying infection or an interaction between infectious agent and the antibiotic. Also, reactions of predictable non-immunological symptoms were mislabeled as allergic reactions like GI upset, falsely elevating the reaction rates. Latest guidelines indicate there is negligible risk of cross-reactivity between penicillins and cephalosporins, but may be higher with R1 side chains. Let's explore this risk further. Multiple publications since 2005 have questioned the prior understanding of a cross-reactivity belief between penicillins and cephalosporins. The strongest data implicating R1 side chain as compared to the beta-lactam ring for hypersensitivity was derived from a study completed in 2018 by Romano and colleagues. The team aimed to investigate potential cross-reactivity with cephalosporins in patients with confirmed penicillin allergies. They completed a prospective review which included 252 patients who had immediate reactions, with 76% of these immediate reactions being anaphylaxis to a penicillin. It's important to note that 94.4% of the patients who reported their penicillin allergy were allergic to an aminopenicillin, amoxicillin, or ampicillin. All patients included had a positive skin test to confirm their penicillin or aminopenicillin allergy. Intervention completed was an IgE assay for cefaclor, as well as skin tests for cephalhexin, cefaclor, cefadroxil, cefamandol, cefuroxime, ceftazidime, ceftriaxone, cefotaxime, and cefepime. Patients with negative results for the later generation cephalosporins were then challenged with oral cefuroxime and intravenous ceftriaxone. Patients with negative results for cefalhexin, cefaclor, and cefadroxil, the aminocephalosporins, were also challenged with oral cefaclor and oral cefadroxil. Of the 252 patients, a third of them had positive cephalosporin IgE test result. This was 99 patients. 96% of those patients, or 95 of the 99 patients who reacted only to the aminocephalosporins, meaning those cephalosporins with identical side chains to the aminopenicillins. Study authors concluded that cross-reactivity between penicillins and cephalosporins seemed to be mainly related to the side chain similarity and suggested subjects with an IgE-mediated hypersensitivity to penicillins could be treated with cephalosporins, such as ceftriaxone, that have side chain determinants different from those of penicillin. As reflected in the latest allergy practice parameter guideline, the latest data on cross-reaction risk between the penicillin and cephalosporin classes indicate the risk is not different compared to non-similar chemical structure antimicrobials like the sulfa-containing antimicrobial class. For example, up to 2% of patients with penicillin allergy labels may react to a cephalosporin, where Up to 1.6% of patients with penicillin allergy labels may react to a sulfa-containing antimicrobial. 10% of the population reports a penicillin allergy label, but less than 5%, using conservative estimates, are truly allergic. In patients who are confirmed to be allergic to penicillin, up to 2% of those may experience a reaction to a cephalosporin when they are given a cephalosporin directly, which results in a probability for a reaction of 0.1%. If we apply these percentages to 1,000 patients who report a penicillin allergy, that converts to 50 patients having a confirmed penicillin allergy, meaning 950 of these patients do not have a penicillin allergy and could be delabeled. Of these 50 patients with confirmed penicillin allergy, one patient of 1,000 patients may experience a reaction to a cephalosporin when they are given a cephalosporin directly. In cephalosporins that share no side chain with any penicillin, the reaction rate is even less than 1%. For example, cefazolin. Latest data shows a reaction rate of 0.7% in patients with unconfirmed penicillin allergy labels who receive cefazolin directly. In order for one patient to experience a reaction to cefazolin, 3,000 patients with penicillin allergy label would need to have been exposed to cefazolin. The risk of a reaction to cefazolin is half that for a patient with penicillin allergy as compared to the same patient receiving a sulfa-containing antimicrobial, which suggests dual allergy as compared to a cross-reactivity. Consider this. Practice does not advise against administration of a sulfa-containing antimicrobial in a patient with a penicillin allergy label, but has done so for cephalosporins despite similar reaction risks. The impact of penicillin allergy labels is profound. Penicillin allergy label is overreported and leads to significant negative impact on patients. Over 10% of the population reports a penicillin allergy, but less than 1% of the population is truly allergic. Penicillin allergy labels can compromise optimal medical care by limiting first-line preferred antibiotic choices, preventing de-escalation, and restricting the use of oral agents. This results in an increased cost of care, a higher risk of adverse drug events, increased C. difficile infections, increased lengths of stay, increased resistance, including vancomycin-resistant enterococci and methicillin-resistant Staph aureus. Patients undergoing surgery who have a penicillin allergy label have a 50% higher risk of surgical site infections and increased revision surgeries, which leads to substantial morbidity and mortality, increased costs, and impact on hospital quality metrics and reimbursement. This association is directly related to patients with penicillin allergy label receiving non-preferred antimicrobials for surgical prophylaxis, such as clindamycin and vancomycin. It is for these reasons that penicillin allergy label, or PAL, is not your friend. It is a barrier to optimal medical care. The CDC has additional information about the impact of penicillin allergy labels. See this information via the QR code noted on the screen. In order to improve outcomes for patients with penicillin allergy labels, there are two main tactics we can employ. First, we need to optimize antibiotic selection to use preferred beta-lactams in patients with penicillin allergy labels. Second, we need to remove the penicillin allergy label in the vast majority of patients who currently are mislabeled as penicillin allergic. Optimizing the use of preferred beta-lactam antimicrobials in patients with penicillin allergy label. For years, practice of using cephalosporins in patients with non-severe penicillin allergy labels was supported. However, avoidance of cephalosporins was recommended in patients with more severe penicillin allergy labels, such as immediate reactions, including hives, shortness of breath, and anaphylaxis, out of fear of a potential cross-reaction. Data over the last 20 years has emerged, and guidelines have now been updated to reflect this low probability of a reaction between penicillins and cephalosporins. Data suggest any reactivity between penicillin class and cephalosporin class, if present, is likely related to the R1 side chain. There are no cephalosporins with identical R1 side chains to penicillin. Cephalosporins with identical R1 side chains to amoxicillin include cefadroxil and cefprozil. Our most commonly used cephalosporins in the inpatient hospital setting at my institution include cefazolin, cefdinir, ceftriaxone, and cefepime, and these do not share a similar side chain to either penicillin nor amoxicillin. Given the data on the impact of patient outcomes for patients having a penicillin allergy label, and the data suggesting cephalosporins can be safely used in patients with penicillin allergy labels, teams have demonstrated safe use of cephalosporins in patients with penicillin allergy labels, including anaphylaxis, in the perioperative settings. Cefazolin is a unique cephalosporin and does not share an R1 side chain with any penicillin or cephalosporin. Publications from 2021 to 2023, including data from my institutional experience, demonstrate almost 800 patients with immediate reactions to penicillin and tolerated perioperative cefazolin without a safety event. These studies were able to demonstrate increased use of preferred beta-lactam antibiotics, improvement of pre-op antibiotic timing goals, less acute kidney injury, which is a known risk factor when using even single doses of vancomycin for surgical prophylaxis. Given most patients with penicillin allergy labels do not have a true allergy, the limited to no cross-reaction rate between penicillins and cephalosporins, the impact on patient outcomes when beta-lactam antimicrobials are avoided, and the emerging evidence demonstrating safe use of cephalosporins in patients with penicillin allergy labels, national guidelines have begun highlighting these concerns and are now suggesting the risk of avoiding the use of a beta-lactam antibiotic in patients with penicillin allergy labels is higher than the benefit. Notably, the SHEA IDSA APIC practice recommendations for strategies to prevent surgical site infections has highlighted that beta-lactam antibiotics can be used for surgical prophylaxis in patients with penicillin allergy labels. Additionally, the National Allergy Practice Parameter was recently updated in December 2022, which now permits the use of cephalosporin antibiotics with unshared R1 side chains in patients with penicillin allergy labels, including those with anaphylaxis history. Let's explore this update further. Previously, the last allergy practice parameter guideline was published in 2010. Significant changes between the 2010 and 2022 guidelines revolves around the impact of penicillin allergy labels on patients and guidance to optimize and improve beta-lactam antimicrobial use in patients with penicillin allergy label, and they emphasize the importance of delabeling penicillin allergy label where able. The guideline update can be summarized by the following. Understand it, just give it, get rid of it, and do it together. The guidelines are promoting teams to better understand patients' penicillin allergy labels through obtainment of in-depth drug allergy histories. They are also emphasizing the limited to no risk for cross-reaction between penicillins and cephalosporins when there is no shared IR1 side chain, and directing teams to proceed with administration of cephalosporins when this criteria is met. The guidelines emphasize the importance of removing a penicillin allergy label and using direct drug challenges instead of skin testing for the vast majority of patients who present with non-anaphylactic, non-severe cutaneous drug allergies to accomplish delabeling. And finally, the guidelines emphasize the importance of collaboration between allergy and immunology providers and healthcare systems to implement beta-lactam allergy pathways to improve use of beta-lactam antimicrobials to improve antibiotic stewardship and patient outcomes. Immediate allergic reactions to cephalosporins in patients with penicillin allergy label appear largely related to the response to the R1 group side chain rather than the core beta-lactam ring or the R2 group side chains. The chemical structures for penicillin and cephalosporins are presented. The beta-lactam ring is noted in green highlight, where the R1 side chain is noted in the orange circle located in the blue box. Amoxicillin and ampicillin have similar R1 side chains to a few cephalosporins. There are no similar R1 side chains noted between penicillin to any cephalosporin, and this holds true for dicloxacillin, oxacillin, nafcillin, and piperacillin as well. The table outlines beta-lactam antibiotics that share an identical R1 side chain for the beta-lactams that are available in the United States, with the antibiotic in bold indicating the antibiotic allergy of interest. For example, if a patient reports an amoxicillin allergy, it's important to note that cefadroxil and cefprozil share an exact R1 side chain. This information is useful to implement optimization of beta-lactam antibiotic selection. Per guideline recommendations, if the amoxicillin allergy was non-severe, such as a rash, then any cephalosporin can be used. Conversely, if the amoxicillin allergy was anaphylaxis and we wanted to use cefadroxil, guidelines would recommend that we complete skin testing first, followed by direct oral challenge prior to using the cephalosporin that shares an exact R1 side chain to the amoxicillin. However, if the amoxicillin allergy was anaphylaxis and we wanted to use ceftriaxone, a cephalosporin that does not share an exact R1 side chain to amoxicillin, it is okay to proceed with the administration of ceftriaxone without further testing or caution per the guidelines. This algorithm depicts the guideline information in relation to using cephalosporins in patients with penicillin allergy labels. It is important to separate out cephalosporins that share a similar or dissimilar R1 side chain from the penicillin implicated in the penicillin allergy label. In patients with penicillin allergy label, where the desire is to use a cephalosporin, it is permissible to administer when the cephalosporins has a dissimilar R1 side chain to penicillin, regardless of the anaphylactic history or not. For example, in a patient who reports an amoxicillin allergy with a history of anaphylaxis, and we want to use cefazolin, ceftriaxone, or cefepime, it is okay to use those cephalosporins even though this patient had reported an anaphylactic reaction to the amoxicillin because of the dissimilar R1 side chains. If the amoxicillin allergy was non-severe, such as a rash, and we wanted to use ceftriaxone, That too is permissible per guidelines, given there is a non-anaphylactic history and a dissimilar side chain. So it's okay to use the cephalosporin in this situation. In relation to using cephalosporins in patients with a penicillin allergy label and they have a shared R1 side chain, the guidelines differentiate between those who have had an anaphylactic reaction as compared to non-anaphylaxis. If the patient has an amoxicillin allergy reported as a rash, and we want to use similar R1 side chain cephalosporins such as cefadroxil, because the patient has a non-anaphylactic reaction, it is okay to administer the cephalosporin. However, if the patient has an amoxicillin allergy and it was anaphylaxis, and we wanted to use cefadroxil, the guidelines do suggest skin testing first, then direct oral challenge to follow as the preferred management strategy given the anaphylactic history and the identical R1 side chains. Overall, you can see that the use of cephalosporins has greatly been liberalized by the guidelines based on emerging data of limited to no cross-reaction risk between penicillins and cephalosporins, the risk of avoiding beta-lactams in patients with penicillin allergy labels, and the data demonstrating safe use of dissimilar R1 side chain cephalosporins in patients with penicillin allergy labels, including anaphylaxis. 0.5% to 2% of the population reports an allergy to a cephalosporin. The guidelines also provide an update and suggestions related to cephalosporin use in patients with cephalosporin allergy labels. The guideline differentiates this out based on anaphylactic history versus non-anaphylactic history. In the case of a cephalosporin allergy with a history of anaphylaxis, the recommendation is to skin test first prior to using another cephalosporin, regardless of similar or dissimilar R1 side chains. For example, a patient has a ceftriaxone allergy with a reported history of anaphylaxis, and there's a desire to use cefazolin, which does not share a similar side chain to ceftriaxone. Currently, guidelines suggest a skin test with direct oral challenge first, but do offer that induction of tolerance procedure could be considered, or a direct challenge of administering cefazolin could also be an option. In patients who have a cephalosporin allergy that is non-anaphylactic, in the case of a dissimilar R1 side chain, it is okay to give a cephalosporin. As an example, we would be able, in a patient reporting an allergy to ceftriaxone with a rash, and we wanted to use cefazolin, which has a dissimilar R1 side chain than ceftriaxone. Given the dissimilar side chain and the non-anaphylactic reaction, it is okay to use cefazolin in this situation. In patients who have a cephalosporin allergy that is non-anaphylactic, in the case of a similar R1 side chain, guidelines are suggesting skin tests first, but drug challenge could also be an option. The example here is a patient with a ceftriaxone allergy with rash and a desire to use cefepime. As ceftriaxone and cefepime have an identical R1 side chain, guidelines would suggest skin tests first prior to cefepime use. In patients who have a cephalosporin allergy label, there's also guidance on whether or not we can use a penicillin in these patients. In general, in a non-anaphylactic cephalosporin allergy label, it is okay to give the penicillin. However, guidelines do suggest that if a patient has an anaphylaxis reaction to a cephalosporin, they suggest skin tests first. For example, a patient reports a ceftriaxone allergy with anaphylaxis, and we would like to use amoxicillin, which has a dissimilar R1 side chain between ceftriaxone and amoxicillin. In this situation, guidelines are suggesting that skin tests first, followed by oral challenge prior to proceeding with administration of amoxicillin. However, the guidelines do permit consideration for a direct challenge without the skin test as an alternative recommendation. The allergy guidelines also have commented on the use of carbapenems and aztreonam in patients with beta-lactam allergies. It is permissible to administer a carbapenem without prior testing or precaution in patients who have other beta-lactam allergies, regardless of anaphylaxis history. In general, this holds true for administration of aztreonam in patients with beta-lactam allergies. However, guidelines do provide an exception for patients with ceftazidime allergy labels, given a shared R1 side chain. Of note, ceftriaxone, a newer late-generation cephalosporin, also shares an R1 side chain with aztreonam and ceftazidime. In patients who have reported a severe cutaneous adverse reaction, such as Stevens-Johnson syndrome or toxic epidermal necrolysis, or one of the other listed scars to a beta-lactam antibiotic, avoidance of other beta-lactams continues to be recommended. Cross-reactivity between beta-lactams in patients with scars appears to be based on the R1 side chain, but data are incomplete. However, the risk of a reaction should be weighed against the benefit of treatment of the underlying infection and the availability of alternative treatment options. Small case series data suggests that some patients with drug reaction with eosinophilia and systemic symptoms, also known as DRESS, from penicillins may tolerate other beta-lactams. Reported cases of scars due to two different classes of beta-lactams are rare, and larger studies are required to determine the safety of using alternative beta-lactams in patients with scars due to a specific beta-lactam antibiotic. Ampicillin and amoxicillin, the aminopenicillins, as compared to other penicillins, is interesting to review and understand. Some patients with immediate type 1 reactions to amoxicillin or ampicillin have IgE antibodies directed at the R1 group side chain rather than the core beta-lactam ring, and they are able to tolerate other penicillin class components. These patients may have skin test results that are positive to amoxicillin or ampicillin, but test negative to penicillin major and minor determinants. Those who experience a delayed maculopapular rash to one of the aminopenicillins are not at risk of a life-threatening immediate reaction when given penicillin. Therefore, consideration of using a penicillin in a patient who's had a non-severe reaction to one of the aminopenicillins is reasonable. Similar information is also available for piperacillin and other penicillins. Patients may have selective allergic reactions to piperacillin and may be able to tolerate other penicillins and vice versa. Overall, in patients with non-severe reactions to amoxicillin or piperacillin, it is okay to trial penicillin. Delabeling antibiotic allergy labels. Because of the significant impact on patient outcomes, penicillin allergy delabeling is an important part of patient care, and we encourage it to become a routine part of patient care. In patients with penicillin allergy label who are subsequently delabeled of their penicillin allergy, overall, they have a reduction in healthcare utilization, including less outpatient visits per year, less emergency department visits per year, and shorter hospital length of stay. Data published on the practice of penicillin allergy delabeling have demonstrated over $2 million saved in a 3.6-year time frame. Updated allergy guidelines indicate that Proactive efforts should be made to delabel penicillin allergy whenever possible, and strong efforts should be made to educate patients and clinicians about the benefits of delabeling, such as improved antibiotic selection, decreased use of broad-spectrum antibiotics, decreased healthcare utilization, and less cost of care. Strategies for management of patients with penicillin allergy label starts with a conversation with the patient about the importance of completing a delabeling assessment. Obtaining a complete penicillin allergy history is key. Once a penicillin allergy history has been obtained, delabeling per institution algorithm can be implemented, with many penicillin allergies being able to be delabeled without having to have an allergy consult. For others, a consult to allergy would be advised if the patient reported a reaction within the past 12 months, had a history of shortness of breath or anaphylaxis, or if the patient was unwilling to complete a direct oral challenge. A direct amoxicillin oral challenge for patients with penicillin allergy label with reactions more than 12 months prior, with any benign rash, GI symptoms, headaches, or other benign somatic symptoms, or unknown reaction history, can be completed. Given additional data and guideline support, cephalosporins with unshared side chains to penicillins, such as cefazolin, ceftriaxone, and cefepime, may be safely used in patients with penicillin allergy labels, including patients with a history of anaphylaxis to penicillin. When implementing strategies for management of patients with penicillin allergy labels, it would be important to track and report your penicillin allergy label delabeling successes. When starting a conversation with the patient about penicillin allergy label removal, suggested scripting may include the following. You currently have a penicillin allergy listed in your medical record. Data shows that the vast majority of patients with penicillin allergy labels are not allergic. Penicillin allergy labels lead to the use of non-preferred antibiotics, and that is associated with increased adverse reactions, including serious bowel infections, antibiotic-resistant infections, higher rates of new drug intolerances, and increased overall healthcare use. Because of this, let's start the penicillin allergy label delabeling process. Providing the patient with additional resource about the importance of penicillin allergy delabeling is key and can be found using the QR code seen on the screen. Obtaining a complete penicillin allergy history will involve asking multiple questions to obtain specific details about the reaction. These will include when the reaction occurred, or the age of the patient when the reaction occurred, how soon the reaction presented after starting the penicillin antibiotic, what was the type and severity of the reaction, and how was it managed, including if medical treatment was sought and if medications were administered to manage the reaction. Inquiring about previous penicillin skin testing and results of that testing is also important. Many algorithms exist related to delabeling penicillin allergy labels based on criteria, but in general, if the patient has one of the following, they can have their penicillin allergy labels delabeled without any testing or direct oral challenges. These include a documented negative penicillin skin test available in the patient's chart. The patient has received and tolerated a penicillin since the original reaction was documented. Or the penicillin allergy label was only present based on a family history. A direct amoxicillin oral challenge for patients with penicillin allergy label with a reaction more than 12 months prior, with any benign rash, GI symptoms, headaches, or other benign somatic symptoms, or unknown reaction history can be completed. It is recommended to document the direct amoxicillin oral challenge in the patient's chart and should include prior penicillin allergy reaction history information and details about the direct amoxicillin oral challenge. In absence of a reaction to the direct amoxicillin challenge, the penicillin allergy label may then be removed from the allergy module within the patient's chart. As suggested by the latest allergy guidelines, direct oral challenges should be considered for most patients with penicillin allergy labels that are low risk. Recent publication in JAMA, called the PALACE study, provides additional supporting data for this concept. The study design was a parallel, two-arm, non-inferiority, open-label, multi-center, international randomized clinical trial occurred in 6 specialized centers, 3 in North America and 3 in Australia. Testing was done in allergy clinics between June 18, 2021 and December 2, 2022. Population was adults with penicillin allergy label and PenFast scores of 2 or less. PenFast score is a prospectively derived and internationally validated clinical decision rule that enables point-of-care risk assessment for adults reporting penicillin allergies. See the QR code for additional information. Outcomes assessed was a physician-verified positive oral penicillin challenge reaction defined as immediate reaction occurring within the hour after ingestion of the penicillin that was consistent with an immune-mediated reaction, including diffuse arrhythmia, rash, angioedema, respiratory compromise, measured by a decrease in baseline oxygen saturation level, anaphylaxis, or unexplained cardiovascular collapse. The groups were evenly split with roughly 190 patients in each arm. Demographics were similar between the groups. There was one reaction in each group with a risk ratio of 1.02, a non-statistically significant finding with 90% confidence interval of 0.1 to 10.34. Both reactions were described as mild cutaneous skin reactions and occurred at 20 and 50 minutes post-direct oral challenges. Therefore, as teams implement direct oral challenges to delabel patients with low-risk penicillin allergies, the expectation would be that most will be delabeled, and for the few that are not delabeled, they may have a mild cutaneous reaction, confirming their hypersensitivity. In addition to clinic settings completing direct oral challenges in patients with low-risk penicillin allergy labels, additional publications are demonstrating similar utility in the inpatient or hospital setting. Recent data from Trubiano and colleagues from Australian practice sites provided specifics on who, what, when, and where for inpatient direct oral penicillin challenges. Their data demonstrated a high prevalence of low-risk penicillin allergy labels, with 558 of their patients being low risk. Of these 558 patients, 29% were delabeled via direct oral challenge, and 178 patients went on to receive a penicillin within the next year, and 244 patients received a beta-lactam within the next year, achieving the ultimate goal of penicillin allergy delabeling, improving use of preferred beta-lactam antibiotic utilization. They also provide information on patients where no challenge was performed. These included patient refusal with 83 patients, critically unwell patients with 57, and clinician refusal in 12, and patient discharge prior to completion of the direct oral challenge in 63 patients. Clinical predictors of successful direct oral challenge implementation, which is their suggested population to target for hospital implementation of direct oral challenges, would include patients needing a beta-lactam antibiotic during an infective admission with bacterial etiology, patients with low-risk phenotypes, such as a childhood rash, those patients who are medically stable, such as a post-surgical inpatient, and those patients who are admitted for greater than 1 day. This data can be helpful to implement direct oral challenges at your hospital setting to increase penicillin allergy delabeling and improve preferred beta-lactam antibiotic utilization. With all the efforts to delabel a patient from their penicillin allergy label, preventing delabeled patient penicillin allergy labels from being relabeled to a patient chart is a challenging perspective, but it's a very important item to consider. Instructions to remove the penicillin allergy label should be relayed to hospital systems, outpatient clinics, private physicians, and dental offices and pharmacies. Patient and relevant family members should be given written documentation, such as a wallet card indicating that they are no longer penicillin allergic and are no longer high risk of developing an allergic reaction to penicillins than the general population is. And if the patient wore a medical alert bracelet, these should be modified. An alert in the electronic health record alerting clinicians of the lack of a penicillin allergy should also be adopted if relabeling is attempted. In summary, penicillin allergy labels are overreported and leads to significant negative impact on patients by compromising optimal medical care, by limiting first-line preferred antibiotic choices, preventing de-escalation, and restricting the use of oral agents. This all results in an increased cost of care, higher risk of adverse drug events, increased C. difficile infections, increased hospital length of stay, and increased resistance. Recent updated allergy practice parameter guidelines have liberalized the use of cephalosporins in patients with penicillin allergy labels, including anaphylaxis, for most frequently used cephalosporins in the inpatient setting, like cefazolin, ceftriaxone, and cefepime. Penicillin allergy delabeling is beneficial in improving patient outcomes, including reduction in healthcare utilization and costs, and should be a routine part of patient care. Thank you for your time and participation in this event. If you have questions, please do not hesitate to reach out to me via the email shared on the screen.